We're pleased to have Eugene Sayan here, who's the founder and chief executive officer of Softheon, to talk and look at the consideration of Indiana as the example of reform and how to modernize Medicaid. As everyone's well familiar with the Indiana program, it is the paradigm and the archetype that many states have tried to duplicate various provisions from. By seeing that it has gone through waiver approval through CMS, and so figuring if they mimic or duplicate a lot of those provisions, it'll ease their transition to submit their own 1115 waivers, and seeing successes of it. And there's been recent evaluations by Lewin and others about the Indiana HIP 2.0 program, and so we'll be focusing on that for this morning's session. Without further ado, I'll introduce Mr. Sayan.
Thank you, Alex. Good morning. As Alex pointed out, basically, we'll have a little extended coverage on my presentation. So late last night, I went ahead, I pulled some of my earlier interactions and comments, morely on the policies and the operations side. As we heard from Mohit this morning, he was talking about the need for data and turning data into the actionable items. To be frank with you, we see there's no place better to apply that challenge, if you will, is to especially the Medicaid space altogether too. A brief intro to myself. This is one of my first, I will say, and hopefully will be a lot of follow-up to this session altogether too, in the government solutions space altogether too. We have been traditionally a technology vendor, especially on the ACA and working closely with carriers. And so we'll give you a little bit of kind of a history and fast forward kind of the past, present, and future of Softheon and how we play, what role do we see ourselves in the HSA-related space and Medicaid, and overall, I will call the consumerization of healthcare altogether too. So why did we start this? I myself and my team, we are a bunch of computer scientists. So we looked into early days and we approached this problem more, I will call it a quasi-academic, if you will, too. Again, there are many references to the healthcare spendings, and let it be 16% or 18% or $3.2 trillion to the $4.4 trillion. It is a big problem. And it is only getting worse. Just last week, we heard about Medicare solvency becoming an issue as well too. And I don't have to tell you about what's happening, obviously, here in D.C. from a political climate perspective. But 50% of every federal dollar spent on Medicare and Medicaid is not a sustainable path to begin with. So what do we do about this? And what are the opportunities? As we all know that there is roughly about 318 million non-elderly who needs the health care coverage. We also know that 40-some million uninsured in the space, and despite all the attempts, I'm not going to get into any political rhetoric, unlike John Gorman does a great job with that piece that I do. I'm not going to compete with him. And you can see that there has not been a lot of interest, let it be for various reasons. And what ended up happening out of 47 million people, that 10 million or so, the sickest people, ended up enrolling to ACA. And as you know, as a result of that adverse selection, so ACA is kind of, in a way, a death spiral, as we call it in Silicon Valley. Sicker people left out, higher premium forcing the healthier people pushing out, leaving the sicker people, and so on and so forth. That is the textbook definition of a death spiral. Okay? And we're going to hit some bottoms, and that's where we are. And to be frank with you, from a membership perspective, that's probably where we are very close in the ACA world. We have reached that bottom altogether too. So what are the opportunities? I think the rest of the presentation we're going to talk about today is on especially in the Medicaid front. As you know, the numbers are, I believe, somewhere in the vicinity of 70+ million people are on Medicaid. And if you add that additional 25 billion coming from the ACA world, or uninsured world, there are going to be about 100+ million people fall into that bucket, if you will. And so what kind of product and services that 100 million people will be looking for it? ACA was the very first attempt to address that addressable market size, as you all know. But we all know that, just as I've heard too many times, if you've seen one Medicaid system, you've seen one Medicaid system. Every state has a different implementation. And unfortunately, some of the lessons really wasn't learned too well. And ACA implementations basically follow the same paradigm. Hence my question about the use of 1332 waivers, about the modularity on MMIS implementations and whatnot too. And we all know what happened as a result of it. We have just about 15 or so states still running their exchanges, many of them struggling. And then we have 35 or so. They choose not to do anything about it. They let the feds do it. And what was basically a plan B, it became a plan A. Federal Exchange, FFM, ended up becoming the plan A. And as we all know today, it's been challenged by GOP many times. And now that with the current administration, there is definitely, if nothing else, a commitment or push towards healthcare back to states and considering healthcare is a local thing, and they're saying it should be handled by the local legislators and local governments. But there was a lot of challenges, So what we were trying to accomplish at the time, what was the challenge? The challenge was about pulling the consumer into the experience of really purchasing the healthcare, being part of a stakeholder during the shopping experience, but all the way back to the consumption. So they will start asking questions. Why is that costing me $10, $20, even a small copay? And if you look into that model, what happened in other industries, one great one will be obviously travel industry. So just to kind of level set is there's a single carrier marketplaces, exchanges. Delta.com will be a good one. And then there are multi-carriers. And the people gravitate towards the multi-carrier exchanges when they are price conscious. If you want to find the cheapest flight from New York to LA, you will go to Expedia, Travelocity. But if you are already a Delta.com frequent flyers and you want to be able to use those mileage points and upgrade yourself to the first class seat and whatnot, you will end up using Delta.com. So once you become a brand aware, a brand loyal, you will end up gravitating towards it. So we felt that was the intent. If not, that was perhaps the path, if you will, where ACA will create that multi-carrier private exchanges. Price-conscious individuals will be able to buy in. But over time, those individuals will be then transferred into the private carriers. And there are so many provisions in ACA, all the way from direct enrollment. For instance, just last year, we've enrolled about 20,000 people or so bypassing healthcare.gov. Those individuals did not go to healthcare.gov. They were enrolled through private carriers direct exchanges. So there's already a movement towards that effort altogether too. So our approach was, okay, let's build that. Let's build it up there. So we took in the phrase is a healthcare supply chain. And we looked into the other industries, how they build their supply chain. So supply chain in the context of, for instance, travel industry, Delta does not know how many websites out there selling their tickets. Literally, they do not know. What makes it possible, a system called Sabre. The Sabre is the intermediary, sits between the suppliers and the demand. It facilitates all the way from price comparisons, shopping, ticketing, reservations, all the way down to issuing the tickets. Another great example will be eBay. Another great example will be Amazon. When you put your product on Amazon, you don't deal with the consumers. eBay does it. eBay keeps track of every bidding. Only the last bid, the winning bid, ends up going to the manufacturer to say that ship that product from your factory to that consumer. We just sold it for you. So we believe that is the expertise needed that lacked in the ACA implementations. And I hate to say it, many of the carriers don't even have that level of expertise because they never deal with this quote-unquote B2C world, business to consumer. So our value proposition was, why don't we become the B2B2C, business to business, Softheon or companies like Softheon, we are not the only one, as the wholesaler, and then we then distribute those products to the different retailers. And we're seeing similar implementation. A good example also, by the way, in healthcare, specifically in healthcare, the use of telehealth. How teledocs doing a better job of, last year I believe they've exceeded 1 million virtual visits, reaching out to the consumers and basically engaging them at the convenience of their location at the times and whatnot, rather than asking them to go see a doctor next day. So that's the kind of innovation as we see it in the consumerization world altogether too. So what we mean by healthcare supply chain, basically, and exchanges or retailers, any exchanges, what we call it, we don't want to just specify just the public exchanges, meaning ACA, federal and state, but private exchanges. Aon Hewitts, and Mercers, and others out there too. They sell your products. As the intermediary, organization like Softheon will then take the data. We will run through the entire gamut of enrollment underwriting. This is exactly, by the way, the plan is in ACA side. This is what we are seeing on the Medicaid side as well too, under the private options. We'll talk more about that. So as an intermediary, we take care of that issue. We make sure it's the right price, make sure that's the right eligibility. One of the big problems was the inaccuracy of the data. As you know, the CMS challenge, carriers' biggest challenge with the CMS, data was coming down, was extremely flawed data. It was incorrect rates. People with inaccurate address locations, out-of-service areas, which then cost the carriers significant sums of out-of-network claims. It was a very poorly designed, poorly executed, just not technology, but thought process. So we circumvent that. We prevent that kind of a bad data going downstream to our carriers, because what we want them to do is to build a sustainable business. We don't want them to be subject to the risk-adverse, risk corridor risk challenges, issues, and whatnot too. And once we then effectuate a member, only then we then send that member downstream to the carriers. This is no different than what Amazon does. This is no different than what Sabre does. This is no different than eBay does. So technology do exist. And let's talk about that. A little bit about us. As I mentioned to you, we're about 150, pushing about 200. We're all computer scientists. I have to be very transparent to you. I never run a health plan. I never worked for a state Medicaid agency or government agency. I know nothing about healthcare from an operational perspective. But the last 10 years, I've been doing nothing but studying healthcare. We were the technology company, built RomniCare. At the time, we were subcontractor to another major SI. We built RomniCare in 90 days. The RomniCare implementation 1.0 back in 2008, 2007, it was a 90-day project and went on time. I have made great friends up there, people like John Kingsdale, people like Kevin Cunahan. Kevin Cunahan, as you know, was the chief marketing officer in the early days of Mass Connector, and then he proceeded to build the Connecticut State Exchange, which was an innovative exchange, because he was the first exchange to buy a COTS platform to run state exchange. And then he proceeded to oversee CSI for many years until very recently. So what we have done over the years, last 5 years or so, we have 60 carriers. We are a private label, white label TPA. You do not know us, you do not see us as a consumer, but we are the one delivering those products and goods and services to roughly about 2.4 million lives on ACA. So it's about 25% of the demand, as we call it, or 37% of the supply actually runs on a platform like Softheon. And that platform, by the way, includes the Indiana population, which we'll talk more about that, as well as Arkansas population, as well as New Hampshire private options and whatnot too. We could use the term Softheon-enabled commerce. We basically manage roughly about $3 billion on member premiums. We are an at-risk, actually, an entity. We are responsible of making sure that consumer understands, they know what that grace period means. We give them gentle nudges and reminders to say, please make a payment, don't lose your coverage, go check your, do your routine checkups, and so on and so forth. We are sensitive to that need. And our business model aligned with it. It is a transactional business model, just as eBay, just as Amazon. Our implementations are not your traditional, the MMIS SI contracts. It's per transaction, per member. So more the membership, better business for us, but we also want to make sure that there is a sustainable memberships. So our cloud today, as we call it, these are our integration points. Just as Amazon is integrated with many other entities, what you can see on the left-hand side, we basically have integrated already with every federal and state exchange implementations. That we use a term that once we build the first road for the first car, it's a matter of adding more cars to it. So our implementations literally now down to days. If you want to take a new supplier, a new carrier to the exchanges, it literally takes days for us to be able to connect them to any one of the back-end retailers altogether. Over the past 15, 20 years, we worked with all the core admin challenges. This is basically the mirror reflection of your MMIS system challenges you have on the carrier side. They too have been using systems that are 15, 20, 30 years old. They don't understand the consumer world. They don't understand the transactional context. So we provide that buffer zone with them. We use social media extensively. We send out messages and email alerts. And we engage consumer in a format they are comfortable with. I don't care what program, what social, Medicare, we all have smartphones. If you want to get in touch with me, just send me a text message with a click here to make a payment. I don't want to call you anymore. I don't want to talk to you anymore. I don't want to go find the internet. I don't want to go. It's right in my fingertips. We do this for all our parts of our lives. Online banking to the paying utilities. Why is healthcare so complicated? Because we choose to make it complicated, to be frank with you. So I'm going to say it in a very cordial way. You are the problem, and you are the solution. As probably Peter Drucker, famous, one of the Peter Druckers, I don't know who said it. Anyway, one slide is back there. We make sure that the financial service is a critical component of the system. Industry, healthcare especially, had zero card acceptance, meaning that using the credit card to convenience-wise altogether too. I'm not going to go into great details about that, but that's how the whole thing started. In fact, we are one of the credit card companies, so we are the PayPal. We are the integrated experience altogether too. So in single sitting, we can actually go from quote to card. And now we're going from beyond the card, we're making your card is an HSA debit card. Not a Medicaid card anymore, not an medical ID card, but it is your HSA debit card. Your HSA debit card is now your medical ID card. That's what we are able to do today. Some of our, what we call our early adapters, we work with all sizes of all health plans, from Kaiser to Premera, Blue Cross to many of the regional health plans that are especially very active, especially in Indiana. And we had quite a few engagements in Indiana. Obviously, that's our entry point to the Indiana HIP 2.0. I mentioned about that. I'm going to skip really, because I know you're here, not to talk about Softheon, maybe ACA, but I want to give you kind of a little bit of our way of just how the evolution has actually started from the early days of ACA and how basically took shape interesting. This is one of the very few data slides. 68%, even though we don't work for state of Washington, but 66, two-thirds of the Washington state population actually runs on our platform. We integrate, we have the transparency. If the member's churning from one plan to another plan, we keep track of those patients with, of course, consent from our carriers. We are able to keep track of those individuals. We're building the next generation care coordination capabilities altogether too, as a private sector. This is at no cost to state, no cost to carriers. We are able to build this technology platform today. So very quick technology. Where we started as what we call it a platform as a service. Over time, I mentioned about our engagement with ACA on the marketplace side, starting with RomniCares, and then we proceeded with Centene. So this is kind of a very fast-moving slide. I'm just going to jump over very quickly. You can see we have a different size and shapes of every retailer, as we call it, and we have different size of shapes of every suppliers from the insurance side. Technology-wise, you're going to start seeing these little chess pieces. These are our components. These are our modular MMIS components, if you think about it. Basically, what they are is give you the EDI gateway capabilities to the enrollment underwriting, premium billings, data analytics, and whatnot. And over the last 4 years or so, we built our best business practices. This is where I believe one of the Achilles heels of the poor results of ACA. This was the reason ACA never took off the way it's supposed to be. Initially, there was a good intent. How many of you heard of the thing called Zone? In early days, there was so much advertisement about Zone. Zone was going to be a place where states can share the data, they can share project plans, they can share their policies and procedures. Unfortunately, never took off. And therefore, states suffered from best practices. Every state went ahead, just as every state built their own flavor of Medicaid. You have a very unique, Medicaid implementations. There is no common set of best practices. That uniqueness, that 2%, 5% uniqueness, you look for it, you pay premium on that uniqueness. Okay? This is almost like having a computer system. I'm going to use a term. I can give you a computer system, 99% uptime guarantee. 99%, that's pretty good. But often we have a tendency to ask for 100%. The 100%, that 1% or 2% you're asking for it, you may actually have to double what you spend on the 98%, 99% to gain that 2% extra. Because you have to replicate your entire system to give that 100% efficiency. And that is a common pitfalls that we fall into it. And that's exactly what happened on the ACA side as well, too. The lack of best practices basically resulted with a very poor execution, poor collaboration between the states, and a kind of everybody went their own little ways. Even though there was one law to be implemented, didn't even have a single amendment. Everybody had the same reading, but everybody walked away with a different understanding. I'm going to go bypass this slide, not to talk more about Softheon and our recognitions, but we are a very financially stable company. We are ranked about number 18 among the healthcare technology companies altogether. Okay, so this is where the HIP 2.0, this is why you came in here. Everything that I told you, it really probably had no meaning to your interest. HIP 2.0. What is it? How it started it? I took the liberty of commenting the Seema Virma's name altogether too. So it's basically a HIP 2.0 especially. HIP started back in 2008 as a kind of an innovative Medicaid program, but the 2.0 was the big disruption. And as you know, the 2.0 was designed and masterminded by Seema Virma at the time, under Governor Pence at the time. And it was funded by 1115 waivers under CMS. So rather than doing a traditional ACA marketplace implementation, rather than doing a traditional Medicaid expansion, at the time, Governor Pence decided to say, we can use these funds let's reform this entire Medicaid system. And that's exactly what they have done. And to be frank with you, probably those two names, Seema Virma and Governor Pence, and now the Vice President Pence, are the two probably most knowledgeable people in the current administration. I will even broaden up that current Congress on the GOP side. And we have to acknowledge and recognize that. There's rather than fighting it, I always say, famous Star Wars, right? Famous Yoda words. Don't fight the force, use the force. So I think that is going to be some kind of a counterbalance up altogether too. So that is the timeline of HIP 2.0, how it evolved. So a quick snapshot, some metrics on the HIP 2.0. It is a private Medicaid option, or called, I believe, private consumer, Medicaid consumer options. There are 3 carriers currently engaged as a multi-carrier exchange, in essence. Anthem, Centene's subsidiary MHS, and then basically you have MedWise up there, another local plan, majority owner of IU Health, owned by IU Health. These 3 plans currently serve, I think, over 400,000 lives. I do apologize. I could not find the most recent metrics on 2016, but so I believe it are up to like 450,000 people enrolled into HIP 2.0. It is a Medicaid platform. It's a Medicaid replacement. It's an upgrade to Medicaid. It's not just ACA expansion altogether, too. Obviously, what makes them really exciting, and maybe this is why you're here today, is their use of what they call a power card. It stands for Personal Wellness and Responsibility. It's not exactly an acronym, but it's the idea about bringing consumer into the conversation. It's not a $0 copay, deductibles, entitlements. You just walk in. The experience has many times been, described by the GOP, having a $5 check. You go to your local grocery store, you buy as much goods as you want, and you walk out, we walk out. Whether you buy just a gallon of milk or you fill up your shopping cart, you still pay $5. That is not sustainable. We will not tolerate, we will not accept that. Now, we understand that, by the way. I'm not by no means, and I have no political affiliation. I want to make it very clear, to make it even more entertaining for you. I'm an immigrant myself. I came to the United States back in '86. I didn't know a word of English, and I'm a Muslim. So I am in the intersection of basically the most vulnerable probably falls into population. But I did manage to go to school, get a job, and graduated. Now that I have the honor and privilege of serving 200-plus brilliant computer scientists. I work for them. They don't work for me, by the way. I call my title's a CEO. The CEO stands for Chief Expectation Officer. My job is to align those expectations. I don't give executive orders. I basically manage those expectations between our health plans, consumers, state officials, federals, and whatnot too. So we'll talk about Power Card in great details altogether too. And then there are some already published metrics around the benefits as a result of the HIP 2.0, which will go a little bit more into great details. Okay, so HIP 2.0, who is eligible? As I mentioned, it's basically our Medicaid population. Anybody under 19 to 64 years old. Anybody is below 138 FPL, just as many other Medicaid expansion states have done it and whatnot too. Okay? They have two basic programs under HIP 2.0. I'm going to go for first the basic component to it. So if you are below 100% FPL, that's basically Medicaid. You can enroll into it. Everybody gets Everybody gets a Power Card. Okay? And basically you have $2,500 a year, your capitated benefits altogether too. You do not have a dental and vision under basic coverage. You have cost sharings that varies and scales up there. Like for instance, your first ER visits is $8, but the second one, it's $25. It's a big jump. It just gives that called the shock to the consumer altogether too. So that pulls you into the conversation. The HIP Plus model is the next tier up, where you do make a contribution towards your Power Card. I don't want to call it HSA because it does not have the HSA benefits. It is not an HSA card. It doesn't have that triple tax advantage of HSAs and so on and so forth. So we are an HSA program manager. We manage that as well for commercial space altogether too. So we'll talk about that, giving that basically clear contrast between the Power Card and the HSA cards altogether too. And the cost sharing, again, it could be as little as $1. You need to make that $1. I'm going to summarize I'll call it a Republican view of healthcare or entitlement programs is based on competence. Earlier, I think we heard about the West Virginians comment about the opioid crisis. Is it a mental disease, or is it something that you bring up on yourself? So competence versus compassionate. I'm going to call my friends from the Democratic aisles. They are very compassionate. They think that healthcare is a right. We should take care of it, which certainly, for the richest nation in the world, yes, we do owe that responsibility. But we also need some responsibility, some competency from individual side to be taking care of their health. We do that for every part of our lives, by the way. How many times do you get some kind of a mailer from your car insurance company? Don't get into car accidents, your rate goes down. Why don't we offer the same concept to the health insurance? Get your flu shots, your rate goes down, premium goes down. We are seeing that kind of incentive programs. There's a lot of smart guys right now, 18-year-old, 22-year-old. They are pitching this exact same idea in Silicon Valley as we speak. And they're getting hundreds of millions of dollar investment for them to create this kind of incentive programs. So let's go a little deeper into it. So what's a Power Account? So Power Account contributions, basically it's very unique to Health Indiana. They were the only one, first time at the time was created up there too. It's a health savings like, HSA like. It is not an HSA account. Everybody enrolled into HIP 2.0 gets their power card. And states will put, I believe, $2,500 every year into it. That's your limit. And if you wanted to start contributing, if you're under the HIP Plus, you can contribute 2% of your income, anywhere from the $1 to $100. And if you miss that, by the way, the grace periods, unlike ACA, is far more stricter. You'll get kicked out of the programs, and you cannot get back into it for 6 months. So it gets that shock, the consumer shock aspect it altogether too. Unlike the HSAs, you have a triple tax advantages on the income being tax-deferred, tax-free as well too, and the investment you make it, and expenditure. Unlike in the HIP 2.0 power card, that the rollover is only about, I believe, is about the 50% of it, the accounts gets rollover, and we'll talk more about that too. So you kind of use it or lose it. Most of the people do use it, and we'll talk about those statistics as we go forward. So again, first, how do you fund the power accounts? Well, you fund the power accounts just as fund your other type of your debit cards. It's a form of a debit card. It gets funded by the states, and then the individuals, depending upon their contributions, they can basically pay by check, pay by credit card, money orders, automatic payroll deductions, electronic fund transfers, and everything else. So right from this point on, if you want to serve the HIP 2.0 population, you need to understand the financial world. This is how any other consumer-oriented organization engages with their consumers. All these things are totally a foreign concept to your managed care organizations. Right from the get-go, they need to be what's called a PCI compliance. Okay? PCI is basically almost like a HIPAA, I'll say more stiff to it. And there is not a single insurance company is PCI compliant. Because it requires a complete audit, your entire IT assets. And for that reason alone, the first attempt immediately, well, okay, give this to somebody else to run this thing. And we just basically break that conversation into two pieces altogether from a consumer perspective. Every time I want to make a payment, I got to go to these people to talk about it. And then I got to call you to say, did you receive my payments? Because I'm at the pharmacy, I'm trying to get my drug, and I've been told that I just got kicked out of the program, but you haven't received my payments. And that's that 1% that you pay premium to keeping those people in the system. So this is the very first major challenge to and as you know, the ACA also dictated that use of credit card, especially at least on the binding payment component to it. And to be frank with you, these are all these incremental things that the straw that basically brought the camel's back. So these are small things, but it is a big, big lifting for insurance companies. Okay, talk about the reconciliation rollover. So power cards are basically installed 120 days after the member benefit program is over. Reconciliation basically checks for it if they consumed all their $2,500. If they have not done so, that money then will be rolled over to their next year's contribution. You're not, in fact, getting that money back. It's not continuously rollover. So the next year, you pay less in terms of your contribution to your HSA accounts altogether, too. So it's still, again, not an HSA, very clearly. There's a lot of, as you know, the Cruz Amendment especially on the BCRA had a lot of elements about HSA. And what's really exciting about HSA, and we take 2 minutes about that, the HSAs are now on the Cruz Amendment, whether it will happen or not, whatever the case, but it will be used for paying premiums as well, too, not just for utilization, which is a huge game changer. Huge game changer. And some of the statistics were published by HIP 2.0. I had an opportunity to, spend some time with Natalie. She's currently the HIP director in Indiana. 37.9 members, for 38% of the members, they used their power accounts, and 46% they used less. So they were able to roll over that to next year, their contribution altogether too. Average expenditure was $1,400. And then basically that 47% or so, they earn their rollover altogether too. And there's an amount that's being passed on to the next year's contribution altogether too. So there's a lot of more content altogether, and I'm happy to share over too. So let's forward a little bit about, again, as I said, I don't think the Power Card is as successful as it is implementation, confidential speaking, that I think there are some challenges around the way it's being administered. It's a little too over-processed, a little too complex perhaps. Let's take a look at HSAs and how we see the HSAs being forming up as the future state. Number one is HSA has been literally almost, I believe, double. Just from an enrollment point of view, there are 20 million people, 21 million people perhaps by now, exceeding that number, has already enrolled into HSA. About 14, 15 million of them actually from the large group market. So it is a new payment method, consumer engagement method for a larger population, not just for Medicaid, not just for expansions, and not just for ACA. It is a definite form of a new form of investment. You may want to call it a new form of these exotic derivatives in financial services. There are 24% of the carriers today offer high deductible health plans. That is the only condition today. HSAs can only be attached to high deductible health plans. So what is a high deductible health plan? So high deductible health plan is that the minimum deductible is for self is $1,300, for a family is $2,600. Maximum out of pocket, apologies for the typo up there, is $6,000 to $13,000. And just irony, as I said, we run significant portion of ACA. Probably about 40%, close to 40% of the health plans are qualified for high deductible, but not marketed as a high deductible by the carriers. They don't even know how to market the product to the consumer. The biggest advantage, obviously, is what we call a triple tax advantage. Number one is your contributions are tax-free. So under the CURE Act, in fact, now the health reimbursement accounts can be form of a contribution, employer contributions, to those HSA accounts. That's the first tax benefit. Second one is that anything that you spend, the distributions, are also tax exempt. And then the third one, any funds that are being kept in the account, rather than losing it, in the case of like HIP 2.0, you can hold on to it. Just like your IRA, just like your SAP and whatnot too. Total assets right now is $41 billion. So individuals with HSA accounts are basically accruing interest on those accounts as the day goes by. So it is a very interesting and exciting form of consumer engagement. And there are some pros and cons. I'm going to jump onto that very quickly. How am I doing time-wise?
You got 15 minutes, so it's fine.
Good, perfect. HSAs and Medicaid options. So this is where I'm now kind of crossing that bridge, in fact, the two intersecting Venn diagrams altogether too. So the pros are the ways viewed. HIP 2.0 was a great case study. It's proven to reduce the rate, exposure rates to the insurance models. It's also proven to be that basically the consumers taking responsibilities and there are some savings. The moment consumers become aware, they start asking questions. They start watching what they're spending on altogether too. And then the proponents of HSAs in Medicaid space, basically they are saying that states will end up saving it because consumer will be engaged. That's their justification of that, by the way, that $700 and $800 billion and reduction of Medicaid coverage, because they're saying that consumer will step up. Of course, there's other metrics about that. The opponents of HSA saying there's too much responsibility on an individuals. They're not well informed, not well educated. Yeah, perhaps, but I think many of them use Facebook. They know how to use mobile phones. They know how to communicate with one another. If we can find the right conversation method, right conversation channel, communication channel, I think that communication barrier, education barrier can be addressed very quickly. Conversely, again, it can reduce the reduction in care because they are now hesitant to spend money. They're trying to be a penny-wise, pound-foolish altogether, too. Again, I think communication can address the problem. And then the other benefit is saying that, like, people cannot make contributions. This is another form of creating shelters for the rich and wealthy. They offset. Now, to be honest with you, $6,000 maximum contribution you're going to make into account. It's not going to make a lot. So we're talking about a lot of investments. We're not talking about being able to divert hundreds of thousands of dollars altogether, too. I think there's a truth to both sides of them. I'm not sure exactly the magnitude of the truth. It basically upsets the balance any point in time. But we do know that there are states that are experimenting with this kind of programs, and I believe also Health in Michigan is another Seema Verma's engagement. She's done some work up there too. Kentucky in the Medicaid space doing something similar to with the work requirements and everything else. And as you know, the Arkansas also did something similar under ACA programs too. Okay, so here's what happens. This is a high level. Shamelessly advertising Softheon again. But in the future state of the Medicaid private options, consumers go in, they do own their shopping, pretty much like ACA. You have basically a series of high deductible plans or other form of plans if you are generous enough in your state to offer. So it's basically the same blueprint as the ACA. Maybe the benefits are a little bit trimmed down, a little skinnier altogether too, and consumer does their own shopping. The technology platform will then be integrated with the MMIS system in the context of a modular MMIS. And we are, by the way, in conversation with multiple states, considering using the 1332 waivers to create these modular shopping experiences for their state Medicaid population altogether too. So the consumer does the shopping, we make sure that eligibility, we make sure that if there's any subsidy component altogether too, interface with the MMIS, interfacing with the state revenue departments, or even possibly leveraging a federal data hub, what's being built as part of an ACA. There's a lot of conversation about leveraging that platform for the purpose of identity proofing, citizenship verifications, name, address verifications, and possibly even income verifications. Once that is done, then the consumers are directed to, as part of shopping experience, while they are on that site, they're going to basically ask to establish their HSA account savings. They're going to ask to fund that account through electronic fund transfer, perhaps, through their bank accounts. They can use credit card to fund that account, debit card to fund that account. Once that is done, they are effectuated, in essence. They're done. And then, of course, then we pass that information downstream to our enrollment underwriting system, which will then pass that information to the carriers. This is what we do today, not what we can do, by the way. This is what we do. Of course, we're borrowing, again, as I said, 80, 90% of the work we've done in the ACA space. On the enrollment component altogether, we receive all the data. Once again, we run through the full-fledged enrollment underwriting rules, rating engines, service area, making sure that everything is in the right place, elements of fraud detections. We have worked with multiple carriers to address an issue called third-party payments. Sometimes they are authorized, sometimes they are not. How many of you heard about the case with the carriers are suing DaVita, the dialysis company? What DaVita was doing basically is diverting the Medicaid population into the ACA plans and turning around and charging them full commercial rate rather than their Medicaid rates. And that deemed to be unethical and perhaps illegal. So that's why they've been sued. And we build a process. Actually, we underwrite every payment in our systems. We don't accept just because it's a valid credit card, just because it's a valid expiration date. We question how is that account payer is related to the person on the policy. And we have built this basically a fraud database altogether too, and then we can keep track of those people away from this thing. And there's a big fraud aspect to it, as you know, especially from the way the Medicaid enrollments are being done all through attestations and everything else. We work with multiple states on asset verification systems. That's another subsystem of the Medicaid platforms are being seriously and looked upon altogether too. Going back to the Medicaid private option component to it, Once we do all that billing is done, consumer pays the bills, and then we then send the data back to Medicaid platforms, and then we finally pass all the data back to the carriers. So that is basically how things work. Okay, lessons learned. How many of you have seen this slide? I'm going to fast forward, and I don't want to put that in writing. And this is what we believe another form of project is going to happen. Question is, do we know what the customer really wants, which is the bottom right corner? All they could be asking for a tire on swinging off the branch. But as I mentioned that too, you are the problem. You are the solution. Okay? Carriers are the problem. They are also part of the solution. We just need to be cognizant of the fact that, again, are we compassionate enough, or do we demand competency? Or can we have both? So, thank you very much, and happy to take your questions.
So we still have about 10 more minutes of questions before we take our networking break. So we have a mic migrating through the audience, so please feel free to ask a question. Well, I'll start off until people are, because we seem to be a little bit sheepish. We will, one of the things you mentioned is obviously there's been a theme of consumerism that's starting to import itself into the Medicaid program. Mm-hmm. And so looking at Medicare Advantage as a bit of an analogy, one of the things that evolved from there has been the Star Ratings program. John Gorman talked about that a lot yesterday with regard to payments, but obviously it's used as a metric from a consumer basis for selecting Medicare Advantage plans. Medicaid is starting to make that turn into that space, and we'll see that debut with the QRS system, which has been mandated by the regulations.
Exactly.
And so one of the things that we sense evolve, especially over the next 2 to 3 years, will be some sort of quality rating system that will be predicated upon different metrics for Medicaid beneficiaries. From your perspective, because holistically you've talked about consumerism and empowering the consumer, what obstacles do you see states having with Medicaid beneficiaries, given the fact that they're disparate, right? There's IDD caretakers, there's pregnant moms and kids, there's a variety of different populations that are going to be focused on different things. What works for a metric for my IDD kid might not necessarily be a relevant metric for dual eligible. So what challenges exist there, and how do you think beneficiaries in Medicaid will leverage the system based on what you've seen in the ACA?
Absolutely. As you know, the QRS was one of the promises of ACA as well, too. Unfortunately, just like many other components of ACA, never got to see the light of day altogether, too. The quality review is a critical component of the consumer shopping experience. We as individuals, we go to Yelp, we go to other places altogether, too. And I honestly don't think that state can build those systems internally, just for the fact that the information is so scattered, so fragmented. Even though they are under the auspices of this big SIs running the MMIS shops altogether too, remember, they are system integrators. They pick a village of vendors under their umbrella they're integrating, and typically those contracts written in a way that budget expense the available time, okay, the deadlines expense the available, the time, or budget expense the available money. Those systems are not going to be robust enough to create that real-time variety of the sources of the data will be aggregated to create a true objective QRS system. Now, the Medicare star rating is a little different because everything comes down to the one funnel at the federal level. Asking each state to create their own star rating type of imagine, what kind of a challenge will that create altogether? So we believe that there are some opportunities in private sector to step in. For instance, today, some of our partners, you see it up here, LexisNexis. LexisNexis basically is our identity proofing systems, Experian. Even in the context of an ACA, they have the contractor Experian to do the identity proofing and address verification. They could not do that through any of the federal systems. CMS couldn't do it. That's why they contracted and they gave it to Experian to do this piece altogether too. And these companies have the means of aggregating data through so many different sources altogether too. Perhaps a partnership with Teledocs. You know, a Teledocs session may end with perhaps some kind of a net promoter score survey to say, how pleased are you with this conversation altogether? And being able to aggregate that provider experience up to the plan level. So I think that the solution probably will come more like the private sector, to be frank with you, just for the fact that things are changing so fast, so quickly, and the states and the feds are not moving fast enough to build that platform that gives that consumer the visibility and transparency. The price transparency is a big thing, as you know, on the commercial side. But companies like HealthSparks and Fios out there too. So the whole ability to shop for basically a service at the point of sale, using provider contract data, using claims data, and we believe those systems will evolve itself into the true consumer rating systems over time at a much faster pace than the feds or the state entities will put up.
Any other questions from the audience? Otherwise, I'll do one quick one. So one of the things you noted when we're looking at the power counts in Indiana, it's a little bit archaic, old school in the sense that a lot of it was predicated upon an actual hard card.
Right.
And you've alluded to the fact that the success of most of these programs is dependent upon a communications channel. Mm-hmm. Do you think that Medicaid beneficiaries would be amenable to the use of newer technologies with regard to smartphones? So, you know, the Lifeline mm-hmm. program, it's still a hard phone, although they're moving to more smartphone usage for the Obama phones for beneficiaries. Do you think use of Facebook, Twitter, and so forth permeates down across income eligibility categories that are in Medicaid such that you could even move these power counts or power count-like creations, entities into the virtual space so they could do it from your iPhone and so forth? Do you see that as a possibility?
It's not possibility. It's already happening.
Okay.
So on the ACA, just take a look at it in the ACA side. You know, if you think about that, Medicaid expansion populations were basically the ACA's integrated eligibility systems were the single door. So that included the Medicaid people coming in, visiting the websites and doing their shoppings and every form of communication. Especially their grievances were made sure that carriers heard it, and they were all down through Facebook and Twitter. I mean, look at our president, his use of social media. Look at his followers. Look at his base. The people that are following him, his base, is using social media. Absolutely. It's already happening. It's one of the key metrics that we keep track of, our social media, how many complaints we got through social media about a plan, about a doctor, about a carriers. And they're definitely inclined to make payments. They're definitely inclined to use their internet websites, and websites already transform into the mobile experience. So they're looking for more and more capabilities. Again, the same population. Look into the millennials. Significant portion of the Medicaid population falls under that group as well too. They're grown up with iPhone. Been around 10 years. To them, there's no prior experience before not having an iPhone. So it is absolutely a must-have for a strong, viable Medicaid program to embrace the social media, to reach out and engage the consumers, not just as a stick, but as a carrot, perhaps.
Thank you. Well, I'd like everyone to thank Mr. Sayan for his presentation. Oh, sorry. We have one last question. Go ahead, ma'am.
that technology is wonderful, but you cannot assume that everybody has access to it. I fight this battle on a daily basis where my patient who needs this cancer medication does not have a cell phone, or they have a cell phone this month and their phone number is different next month. They've got a cell phone that they haven't set up their voicemail on because they don't know how to do it, or they have their voicemail set up, their voicemail box is full, I can't leave a message, they don't know how to access it. So there is still a huge geographical nuance to technology, and I find it from Southern Virginia across the South, down as far just north of Florida, and across the Bible Belt. So we still have a long way to go with technology for this population.
That's a FCC Ajit Pai broadband access thing, so much taken into account. So thank you so much for your presentation. I would like to make a logistical note that we're now entering into our networking and refreshment break, and that the Innovation Summit will reconvene in Ash Grove Ballroom C, and I'm looking at our conference folks to make sure I'm saying this right. And Medicaid will reconvene in Fairfax Ballroom A. Refer to your program guide for additional direction, but it's all centrally located. So thank you, and we'll reconvene to your different sessions at 10:45.